I'm Caitlin Hicks. I'm a vascular surgeon at Johns Hopkins University School of Medicine, and I do a lot of research related to diabetic lower extremity disease, including peripheral neuropathy and diabetic foot ulcers.
And I'm Katie McDermott. I'm a general surgery resident at Johns Hopkins. I'm interested in vascular surgery and surgical disparities. And I work with Dr. Hicks.
So Katie, why don't you kick us off to talk a little bit about the article and how in its inception that we're going to discuss today.
Dr. Hicks and I and Elizabeth Selvin, who is a clinical epidemiologist at Johns Hopkins, who has done a lot of work on the epidemiology of diabetes and complications thereof, wanted to do a review of the epidemiology of diabetic foot ulceration. Diabetic foot ulcers are a common and highly morbid complication of diabetes. I think any physician who takes care of patients with diabetes is aware of this, but there wasn't a high quality, overarching publication that described the scope of the problem and its associated risk factors and subsequent clinical sequelae. And then kind of what we found as we were going through the literature is that, especially in the US, but globally, we really couldn't talk about diabetic foot and limb complications without talking about racial and socioeconomic disparities. That was the impetus of an evolution of this review.
And so we ultimately decided to cover sort of a global picture of the presentation, etiology, and characterization of diabetic foot ulcers, how we think about classifying and staging different foot ulcers, because the common language about different degrees of disease is really important when you talk in the literature across institutions or even across countries. We did an overview of the epidemiology of diabetic foot ulcers and discussed risk factors for diabetic foot ulcers, as well as their associated morbidity and mortality. We spent a little bit of time discussing the economic burden of diabetic foot ulcers, primary and secondary prevention techniques for the formation of diabetic foot ulcers, and then finally, how diabetic foot ulcers impact quality of life and functional impairment. And so within each of these categories, we discuss sort of more globally the overarching themes, and then in detail how socioeconomic status and race and ethnicity plays into those themes. When we talk about the presentation and characterization of diabetic foot ulcers, there's sort of a wide array of things depending on how you're discussing them. But we know that diabetic foot ulcers really form from a variety of different issues, including neuropathic issues, traumatic issues, and ischemic issues, which all come together ultimately to form an ulcer breakdown, which can lead to limb loss. And in fact, among patients with diabetes, approximately a third of those patients will develop a diabetic foot ulcer in their lifetime. When we talk about things that put a person or a foot at risk, major morbidities include retinopathy, cardiovascular disease, kidney disease, smoking, weight loss, and slightly surprisingly, inactivity, although I think that's a little bit of a surrogate marker for some of the underlying comorbidities of patients affected by diabetic foot ulcers. We know that peripheral artery disease and peripheral neuropathy are major players or major risk factors for the formation of diabetic foot ulcers. And then structural deformities of the foot, including prior ulcerations, things like edema, calluses, midfoot collapse, or Charcot-arthropathy can also put people at risk for this.
Yeah, I think one of the challenges in reviewing literature on diabetic foot ulceration and generalizing findings either about risk factors, about course of healing, or about efficacy of treatments is the variety of scales or scoring systems used to categorize diabetic foot ulceration. I think most systems contain some component evaluation of ischemia, ulcer characteristics like size, location, presence or absence of infection, and or presence or absence of neuropathy. Those all sort of align with risk factors for ulceration and with the potential for healing. Common systems that are used kind of historically, the Wagner or Megget-Wagner system, which is simple. It assigns ulcers 1 of 6 grades based on wound depth and extent, and then the presence of infection. More recently, especially in the US, the Wi-Fi, wound ischemia and foot infection classification system, has gained popularity, especially among vascular specialists, which categorizes limbs as a stage based on, again, sort of ischemia, presence of infection, and wound depth and size. And then additionally provides some evidence-based guidance about whether or not and to what extent someone who has a diabetic foot ulceration might benefit from revascularization to improve healing and promote wound preservation. Other commonly used international schematics include the PEDIS system, perfusion, extent or size, depth of tissue loss, infection, and sensation classification, which has the benefit of also including measures of neuropathy, and has been widely utilized, especially in low resource settings where you might not be able to get information used in the Wi-Fi about degree of ischemia.
We think about the global prevalence of diabetic foot ulcers, approximately 40 to 60 million people are affected. That equates to about 6% of the global population, which is a really large amount when you think about it. The prevalence or risk of diabetic foot ulcer is higher in people with type 2 diabetes compared to type 1 diabetes, likely because people with type 2 diabetes tend to be older and have more related comorbidities. And wound healing times are really quite long. You can get wound healing times over 6 months, depending on the degree of the wound. And once patients achieve wound healing, the risk of recurrence is substantially higher. 1-year recurrence rates for diabetic foot ulcers are estimated to be somewhere between 20 and 30%, depending on the population. There are a lot of risk factors for diabetic foot ulcers and the associated morbidity that I think was probably don't need to go into too much detail here, but one thing that's really important to understand is the risk factor according to race, ethnicity, and socioeconomic status.
Yeah, so a lot of these data come from Western countries, so the US, Canada, Western Europe, the UK, so may not be generalizable, but in those nations, patients who are Black, of Hispanic ethnicity, or other non-white race or ethnicity, in the US and Canada, sort of Native American, American Indian, or sort of Native Canadian populations, for example, have much higher rates of diabetic foot ulceration compared to white majority adults with diabetes. This tends to be true even when controlling for other risk factors for foot ulceration, although those minority populations also have higher rates of risk factors that we've already discussed that contribute to risk of foot ulceration. And then, importantly, adults who present with diabetic foot ulceration who are non-majority race ethnicity often have higher rates of major comorbidity or major consequences, or major adverse clinical outcomes like amputation and mortality.
So lower extremity amputation is probably the most feared outcome related to diabetic foot ulcers. And we know that approximately among people who have a diabetic foot ulcer, approximately 20% of them may suffer a lower extremity amputation in their lifetime. This has stayed relatively stable or even increased slightly in the past 5 or 6 years, and is disproportionately affecting younger patients and Black and Hispanic groups, which is particularly concerning given the already wide inequities in care for racial and ethnic minorities. Also concerning is the fact that after controlling for diabetic foot ulcer incidence, patients of Black or Hispanic origin tend to have lower attempts at revascularization prior to amputation for a diabetic foot ulcer, and then higher rates of failed limb preservation, which is really not surprising. The other major consequence of a diabetic foot ulcer is actually an increased risk of mortality, and it's not something that we more classically think about, but in fact, survival in patients with incident diabetic foot ulcers is significantly worse than that of people with diabetes that do not have foot complications. A recent meta-analysis actually showed that 1-year mortality rates among people with diabetic foot ulcers are approximately 13%, and 5-year mortality rates of nearly 50%, which is just astronomical. Likely this reflects some of the comorbidities associated with people with diabetic foot ulcers, but is certainly a really critical thing to understand when we talk about the consequences of this disease.
And then sort of other often cited and well-studied statistics about mortality in lower extremity complications from diabetes are that lower extremity amputation, whether a minor amputation or a major amputation, both confer very high risks of mortality, with 5-year mortality up to 80% following a minor amputation and as high as 90% following a major amputation.
I think when we talk about this, the big question is, what can we do about it, right? There's a lot of discussion of the fact that we all know that diabetic foot ulcers are bad. And so the major focus nowadays is really on preventing them. So primary and secondary prevention of diabetic foot ulcers relies on guideline-directed screening and management for people who are at risk for developing a diabetic foot ulcer. Foot exams are extremely important. Patients with diabetes are supposed to get at least annual foot exams, and they should be performed more frequently in people that are at high risk for diabetic foot ulcer formation, which includes things like having had a prior ulcer, having an abnormal pulse exam, the presence of neuropathy, etc. The American Diabetes Association outlines the expectations for guideline preventive screening for diabetic foot ulcers quite nicely. And it's important that primary care physicians and anybody really who cares for patients with diabetes are familiar with this. There's also some emerging modalities for self-screening and detection of diabetic foot ulcers. There's some telemedicine-assisted exams that people have moved towards, some temperature detecting socks that have been used to sort of detect changes in foot temperature that may happen when patients have the formation of an ulcer occurring before it's actually clearly obvious to the visual inspection. There's some offloading technologies that allow for pressure differentiation across the foot when patients with diabetes are walking, and some monitoring technologies that allow for the tracking of these different pressures, so that we understand when patients are putting excess pressure on a certain area of the foot, and potentially this can be intervened upon early enough to prevent the formation of repetitive trauma, a callus, and then an ulceration.
The impact of both active and healed foot ulceration on quality of life and functional status is an increasing area of research, which kind of aligns with a shift toward emphasizing the importance of patient-centered and functional outcomes in diabetic foot and limb care. The findings of poor quality of life, especially related to physical functioning in adults who have active diabetic foot ulcers, are fairly consistent. The psychological or socio-emotional sequelae of diabetic foot ulceration are less so. There's some evidence that adults with diabetes who have depression are at increased risk of ulceration and vice versa, although the exact relationship between depression and foot complications is still not well elucidated. And there is some evidence that suggests that both physical and emotional distress or poor functioning that's associated with active foot ulceration tends to improve back to baseline after ulcers have healed, even with minor amputations. But kind of generally, this research as a field is limited by small single center studies and a lack of long-term follow-up. So a better understanding of the functional and quality of life consequences of both active and healed foot ulceration is an important area for future research.
Finally, every time we talk about diabetic foot ulcers, something that has to be brought up is the economic burden related to the disease. Diabetes care in the US accounts for approximately $270 billion annually in direct costs, and maybe $90 billion in indirect costs as well. Adults with foot complications related to diabetes have annual expenditures that range from 50 to 200% higher than those baseline costs. So just an astronomical burden on the healthcare system. The time from wound presentation to healing, as I mentioned, can take anywhere from 6 months to a year and can cost the healthcare system over $50,000 per wound episode, depending on the severity of the disease. And that's just for a simple wound that's being treated largely in an outpatient setting. The direct costs related to major amputation are substantially higher than that. And if you try to get a sum total of the economic burden of diabetic foot ulcers, it's actually quite difficult because you also have to understand the out-of-pocket expenses, the loss of productivity from the person affected by a diabetic foot ulcer, and decreased employment opportunities, both by the patient and their caregivers that are associated with that. And those are very hard things to quantify. And therefore, prevention is extremely important, both from an economic standpoint and a patient morbidity and mortality standpoint.
So diabetic foot ulcerations are common among adults with diabetes, especially older adults and those with a long duration or inadequate glycemic control. Despite well-known risk factors, preventive efforts on a broad scale, both in the US, which was our focus because we practice here, but also globally, have lagged behind the major economic, clinical, and quality of life functional burden that diabetic foot ulcerations present. Strategies to improve compliance with screening, to grade and stage ulcers consistently to allow for comparisons, to address inequities in screening and treatment of ulcers, and to manage comorbidities that increase the risk of ulcer formation and failure to heal are all necessary to reduce minor and major amputations and mortality that are associated with diabetic foot ulceration.